So the etiology of the MPNs, I do have to talk a little bit about the biology because it'll make sense why we treat the MPNs and what types of therapies we do. So as I mentioned before, the biology is the same across these three. There's a mutation in the DNA from these patients that is acquired at some point in their lives. And this mutation is commonly called JAK2 or CALR or MPL. And I make the analogy of a light switch to my patients. Imagine you have a regular healthy person that can make the red blood cells and they can make the platelets. But at a certain point, we can stop making red blood cells and we can stop making platelets. But that's not really what happens in myeloproliferative neoplasms. Because of this JAK2 mutation, I make the analogy that the light switch is always on. The red blood cells keep being made and they have a really big difficulty stopping it. So what has happened is what we call activation constitutively of this really important pathway called JAK-STAT, where things continually be made in a realm called inflammation or a lot of activity. So specifically, this JAK2 mutation lies on a lot of important receptors on the patient's stem cells. EPO on the left, TPO on the middle, and GCSF on the right. And what happens is that once the JAK2 mutation is kind of in the always on position, when the EPO receptor is activated, you get quite a lot of red blood cells. When the thrombopoietin receptor is activated, the middle one called MPL, you get a lot of platelets. And similarly on the right side, when the GCSF receptor is activated, you will get a lot of white blood cells as well too. So the genotype, meaning the mutations of JAK2, they lead to the phenotype, meaning how the patients present with all the increased production of all these blood cells. But as I mentioned, when the factory is always on, the lights are always on, there's quite a bit of inflammation, and that leads to a lot of scar tissue in the factory of the blood cells, and that's called the bone marrow. So when there's a lot of scar tissue or fibrosis, what happens is that there's not a lot of space for the blood cells to be made anymore, and you become anemic with low red blood cells, or thrombocytopenic, or low platelets. So the disease can transform with the constant activity from this disease, from the mutations. One important point that I always talk about with my patients is that these mutations are acquired at some point in their life. They're not inherited from their parents. So the natural history of these diseases, ET and PV, I think of more the early forms of these diseases with increased red blood cells and increased platelets. These diseases can progress across two different axes. Number one, as I mentioned before, with the ongoing activity, scar tissue can really develop, as you can see on this left side of the patient's bone marrow biopsies, with the scar tissue or fibrosis highlighted by those fibrotic networks in dark blue. With ongoing activity and time, you can see that the scar tissue develops further and further, and the disease transforms to either a secondary myelofibrosis, or patients can be diagnosed at that time, and that's called primary myelofibrosis. When we get to the myelofibrosis stage, you can acquire many more mutations outside of JAK2, CALR, and MPL, and that leads to a lot of instability, also leading to another condition called acute myeloid leukemia or blast phase myeloproliferative neoplasms. That's a condition that's very, very challenging to treat. And soberingly, we don't have any therapies in 2024 that really meaningfully prevents progression in either of these axes for fibrosis accumulation or for progression to acute leukemia. So key takeaways from my brief overview are that MPNs are rare cancers. They're diagnosed late in life. The phenotype includes the elevated blood counts. There are many symptoms that I'll be talking about that's due to inflammation. The main mutations are JAK2, CALR, and MPL. And the main outcomes that I wasn't able to talk about out of brevity of time are blood clots and progression to acute leukemia.